Good afternoon, everyone. I'm Bruno Nahar, and along with my co-moderators, Dr. Benadir and Dr. Feinberg, I'd like to welcome you all for this afternoon session. We have a stellar lineup of speakers this afternoon. We're going to be focused on most of the practical and clinical aspects of focal therapy. So without further ado, I'd like to welcome our first speaker, Dr. Rastinehad, who's going to speak on starting a focal therapy program.
Thank you very much. Thank you, the organizers, for having me attend and speak today. This is one of my more favorite talks to give because things have kind of changed over the last 12, 14 years doing this. But the purpose of today is to give you the opportunity to ask questions. And if you're unsure, there's no bad questions. We really want you guys to get engaged with the process. Focal therapy, there's a few aspects that we always have to understand. What's our goal? We want a minimally invasive treatment that controls the cancer while maintaining a man's quality of life. Can we select the right patients? You notice I crossed out the word low because it's really an intermediate risk prostate cancer. We need some adverse events to occur, and if we only treat grade group 1 disease, it's going to be really hard to prove or feel that we'd be able to control the disease. We talked about the benefits and then the types of therapy techniques. These vary. These are going to be challenges that you need to decide which works for you. Where's the cost point? How do you integrate this into your hospital? Which one do you feel most comfortable with? And a lot of it has to do with who your friends are and who's going to help support you and grow in this field. The benefits, it's a targeted treatment. It's an outpatient same-day procedure of the prostate. We talk about the reduced side effects. Shorter recovery time. For cryo, my patients have a catheter for 1 day, comes out the following day, and they do very well. A lot of people leave it for 3 to 5 days, which is not wrong, and I only give antibiotics while the catheter is in. And I think one of the important aspects that we all understand that we don't burn that oncologic bridge. There's still opportunities to salvage and control the disease even after if focal therapy has failed. And another part of what we do in prostate cancer is treating the entire patient. 40% of patients have treatment regret after having surgery or radiation. I think that's something important that's an unmet need in our field to hopefully better illustrate these challenges and go through these things with our patients. The essentials of a program, communication. I made jokes about my radiologist and what scans, the precise score, the PER, the target. It all helps us communicate better. That was the whole purpose of PIRADS. On the back of the PIRADS document, probably the only thing that I feel like was really important that we got in there was the lesion-based reporting. A simple format with no real run-on sentences. T2 is PIRADS what? DC or DWI is this. DC is that. And then it gives an axial slice number from sequence number 3 to allow you a roadmap to get to that area. High quality imaging. I have an MR technologist that travels around to all the hospitals. We do QA once a month. We have bad scans. All those scans are evaluated. If a patient is put in head first, I go absolutely crazy. There's no reason for a patient to have an MRI that goes in head first. That was when we first started, the magnets couldn't tolerate, like the fusion biopsy system, and the magnet had to be aligned because it couldn't compensate for the Z-axis, at least the UroNav, when it was a research device, you could only go in one way. But now that today does not exist, so patients should always go feet first. And I think it's, who's had a prostate MRI? Pelvic MRI. It's really scary going head first into a gantry compared to going feet first, because when you look up, you can at least see out, and you didn't spend half the exam going inside. So I think that's really important. My timer's not going, by the way. And choosing the right modality that's cost-effective and versatile and easy use. How much can you do, and what can you do for your patients? We always include this: garbage in, garbage out. I can't say enough about the quality of your MRI, but also the quality of your biopsy. Are you recording all your 12 cores plus your targeted cores? Are you clearly understanding what has happened during the procedure? Did you have good co-registration? Did you have difficulty with the pubic bone, where you're not able to get a needle in because the pubic bone is a narrow pelvis? These are things you have to know before you get to focal therapy. Ordering the MRI, I just had a conversation this morning. My radiologist and I are in a little bit of working through some challenges. We stop putting the PSA in. We say the last PSA was 6 months ago. We say what it is, so they have the history, family history, prior negative biopsy or prior positive biopsy on active surveillance or planning for whatever it is. But we're leaving the PSA blank in the PSA section because they have a button that populates it directly into their reports. I stopped doing it because I'm like, you guys keep putting the old PSA in and you're supposed to be hitting the other button on your console that pulls up their recent labs, and they haven't been doing it. So we're in a little bit of back and forth. But you don't operate without imaging for kidney cancer, and you shouldn't be having your radiologist work without your history. And I think that's really an important aspect, and it makes their lives easier. Team building. You can't do this alone. When I left the NIH, I was under the impression that I wasn't going to have anyone to support me, but that does not exist today. You have to have a team approach to this. I talked about my MR physicist, our MR techs. I had someone that placed all my balloons for me, my endorectal coil balloons. She was amazing and really was gung-ho and excited about prostate. And you have to cultivate these relationships. You have to have a GU pathologist, of course, because of quality control, because sometimes your pathology doesn't align correctly. At one institution I was at, the path wasn't making sense. And I was like, why are my targeted biopsy all coming back lower risk than my standard biopsy? And there was a different team reading it, and I was like, why? And then I had everything reread, and it all flipped around, and I was like, how is that possible? So only GU pathologists, if you can really have that, that's a luxury that I really recommend. Office staff, working on navigation and communication, there's a lot of steps. We used to do a horrible job at this in my institution, 105 days from an elevated PSA to a biopsy, and people were like, it seemed fine because none of the urologists were really concerned about prostate cancer. However, patient perception, we weren't addressing their needs in a fashion that was consistent with the risk that they had. They thought they were going to die of prostate cancer. And we really took that down to 28 days. We started an RDP like they have at the NHS, and we're down to 21 to 28 days on average, and it fluctuates depending on patient preferences. We have our ACPs do our PSA intake. It really helps the program become really smooth because otherwise, there's a lack of urologists to see these types of patients. And if you can organize everything, it's really a benefit for both sides, you and them. Dedicated radiology team, this is always a challenge. They have to at least read 50 prostates per year to maintain a minimal skill set. Junior and senior, we do a buddy system. So it's always a challenge, but we have overreads, we have people that put addendums on, we have QA, and we have, if you start, you're not allowed to sign a report without a senior radiologist looking at your report for the first, usually 3 to 6 months, so you meet your requirement. RadPath follow-up, a closed loop system. Recently, my software engineer has created a dashboard that tells us how well we do our biopsy. If someone has bone or muscle on the biopsy, it gets flagged for case review. And we're working to implement this across all our radiologists or all our urologists. And we're going to flip it around and use it for our radiologists to know where they are on the curve with predicting tumors. So it's exciting stuff. Treatment planning, historic, I've gone over this. The idea of using this fusion biopsy approach for treatment. We're able to create these basic 3D models from your biopsy to then take that to the treatment plan. Again, starting a focal therapy program, this is the original way we used to do this. Mark the sphincter, mark the lesion, the predicted ablation zone, all drawn by hand. And besides just doing the procedure, you have to make sure you're not deforming the prostate too much because you can move the lesion out of the way of your treatment zone, and you may result in undertreatment of the disease. So if you start early, start with a larger margin. Always review the prior fusion biopsy to know if there was deformation, do they have good alignment. All these things will impact your success in the future. I showed this in my fusion talk this morning, but what's the future of focal therapy planning? You're able to identify the lesion in the right peripheral zone. Here you see right mid PZPL, add a margin. I really feel like I used to make fun of this, and I told you I did not think it was necessary. After having it and not having it, I get really annoyed because of the extra steps. You see a beautiful 3D model in the right lower quadrant. We also use this for surgical planning now to decrease positive margins. We just blow up that screen and pump it into the robot, so you're able to have a map of where the tumors were, and we also mark where the positive biopsies are. I talked about the surgical navigation, but also this is intra-op. You can see where the trocars align, the ablation zone, image in the transverse and sagittal planes to really see what's happening. It's always important to have active imaging. As you know, Tom says, he freezes right up to the rectum and sometimes into it. As long as you're not more than 5 millimeters into it, he's not too worried. I try to kiss the rectum, but not really freeze the rectal wall. You can use hydrodissection or spacer or options for this. But this allows you to track where you've ablated. So if you want to use 2 probes and you need a third one, you can just move one and keep track of what you've already treated in your treatment plan, which I think is what's really important that I really like about the approach. I mentioned the surgical navigation aspect of this, and I'll show you how we just blow it up. And I think sometimes you're tired, the right, left, people can get confused. What's the right, what's the left when you look at your MRI? When we all operate, when you do your radical prostatectomy, who sketches out on a piece of paper where the positive sides were so you know where the disease was, or do you just remember? I used to always put it on the wall next to me because so much stuff is happening. I don't want to get up from the console and look, but you're able to have this map of the pelvis to localize. And we did show this decreased positive margins by 50%, which was pretty incredible because we didn't think it was going to have that big of an impact. And that was published almost 4 or 5 years ago now. Modalities, there is a slight difference in some of the success rates of the modalities that are published. And that really is a challenge, and there's so many factors that go into it, so it's really hard, but I wanted to just show that there's some heterogeneity out there, and you guys should be aware of that when you're choosing your different approaches. We have a certification at our institution that we're employing, but I think it's important to understand the progress of the skill sets and how to move through to develop this proctoring to execute high quality focal. And I think almost everyone in the society has gone out of their way to be available to help train other people. I think there's so many people who have come visited myself as well as all our colleagues around the world. It's been a really good camaraderie to build this space. The QA we talked about, but patient-reported outcomes are key. We collect PROs on all of our patients now that have a C61 code. They get it twice a year regardless, and they get that digitally, and they don't fill it out when they come to the office. The front desk says, could you please fill it out? You just receive the text message that your survey still is not done. So they do that while they wait. We are really trying to incorporate this because a lot of places don't always check the PROs or have a validated questionnaire for this, and I'm really happy about doing this. This was a heavy lift for us. Patient education, informed consent. The companies and vendors for different focal therapies do provide you with videos and instructions. We last year recorded several videos for patient education that's on the focal therapy website for patients to review, and you can use some of the content. It's for your own education if you like for your patients. So there's a lot of stuff happening there. Don't forget shared decision making, going through all the options. I really spend a lot of time with the patients discussing this, but I do have a canned talk. We break it down and we move through the process very quickly. Integrating focal therapy into clinical practice, this is kind of our cycle, the RDP, which is our pathway to the top of the funnel, high quality MRI, shared decision making for prostate biopsies, and determine who should go to that. Then the next step is the closed loop feedback to give feedback to our doctors. Some people get bone, some people get skeletal muscle. We have 30 people doing fusion biopsies. So there's a lot of heterogeneous outcomes. Treatment, should they have axonal focal or Hoare gland, and the PROs, which I think is really key. Speaking a little bit about reimbursement and regulatory concerns, it's always a challenge, depends on your institution. We don't really take cash at Northwell at all, so there's no other cash payment doesn't work for us. You know, the regulatory compliance, IRBs, putting things together to make sure you're able to run an adequate trial. Please be involved with a registry. And all of these things will help push the field forward. I really am always concerned about the financial toxicity of focal therapy because some people, patients will pay anything to get rid of their cancer, and sometimes they don't need any treatment at all. And I think these are the challenges that we're here to do the right thing for the right patient with the right disease. And that is how to start a focal therapy program, and I appreciate everyone's time. Thank you.